Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high-perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
Okay, good afternoon, everyone. Good afternoon, Chairman. My name is Casey. I'm an intensivist and a respiratory physician from the National University Hospital in Singapore. So I'd like to thank Dr. Kwan for inviting me to talk about this topic on dispelling hemodynamic myths and misinformation in sepsis. So this has been quite a difficult talk to prepare for because I'm sure every one of you, including your grandmothers, know what sepsis is. Yeah, so because it's such a well-known topic, it's hard to actually find things that, perhaps we are misinformed about. But then again, I think one reason why it's so well-known is because it is a very severe illness. This is a graph from Kokkonen that Matt has shown us. And 13 years ago, we had a sepsis mortality of about 35%. And despite the advances of technology, advances of training over the years, we still have a mortality of nearly 1 in 5. So for every 5 patients with sepsis, 1 person still suffers mortality. So this is a really important problem, and if there's anything that we can do to adjust our treatment to make it easier, better, and faster, I think we should, look at it more in detail. So let's come to something familiar. Let's start with something familiar. We have a 60-year-old man that comes to our emergency department with acute onset of cough over 2-3 days, rusty phlegm. I'm sure you guys would immediately think of pneumonia, right? He has fever, confusion, a systolic blood pressure of 90, and a respiratory rate of 25, a little bit fast. So we know that according to Matt, that the SIRS criteria are out of the window. We don't have to know about it. And instead, we should use this. So this is a nice little mnemonic that if, let's say you have trouble memorizing the 3 criteria, it's a HEAD criteria, okay? HEAD criteria. Hypotension, altered mental status, and tachypnea. So let's see how our patient matches up. So you just need to fulfill 2 out of 3, remember. Well, he has a source of infection that could be identified. He has hypotension, he has confusion, and it's tachypnea. So this guy has sepsis. And what do we do after we identify this guy with sepsis? Of course, we can go on to calculate the SOFA criteria, but I suspect few of us will actually will do it. I wouldn't. Yeah. And I think the Surviving Sepsis campaign has been the preeminent set of guidelines that we need to do within a certain time period. And these are actually several. So within the first 3 hours, we actually have to measure a lactate level, be it venous, capillary, arterial. And we have to also, among other things, administer a large amount of crystalloids, 30 mils per kilogram of crystalloids if the patient is hypotensive or having a lactate of more than 4. Then after doing that, we have to make sure the patient is well and apply vasopressors. And with vasopressors, a lot of times we do try to set an intra-arterial line. And I've seen a lot of people struggling to put a line into a small patient in the middle of the night with somebody when the patient requires vasopressors. And not only that, the Surviving Sepsis campaign actually behoves us to repeatedly examine the patient, for recovery or for worsening. And we have to do several things. We have a choice, of course, 2 of the following: measure CVP, measure the central venous oxygen saturation, do bedside cardiovascular ultrasound, which is increasingly being done throughout the world, and of course doing other things like passive leg raising. So, we have to ask ourselves, if you have to do so many things, we probably need an ED like that, right? Well-stocked, no patients, Okay, we have lots of time, But okay, whose ED looks like that? Nobody, right? Yeah. So I think our ED looks more like that, okay? It is not necessarily chaotic. It's not chaotic. It's still very well run, but it's busy. And then we have no time. We have no time to go through all these things, And I think if we have to go through the entire bundle promulgated by Surviving Sepsis campaign, we will miss many patients with sepsis, for sure. And we will undertreat many people because we just don't have the time for that. So let's try to examine which parts we could actually improve on. I'll draw our attention to 4 things. The first is lactate. I think it's a keystone that we are of sepsis management that we are doing over the years. Fluids of 30 mils per kilo, an IVC echo. So cardiovascular ultrasound is being widely taken up by a lot of people, and many people actually like to do the inferior vena cava echo. And of course, arterial BP measurement. So why lactate? I think the lactate is because a lot of us are taught that hyperlactatemia represents tissue hypoxia. And is in fact thought to be superior to just measuring global hypoxia alone using SCVO2. So we know that, of course, hypoxia causes higher mortality compared to normoxia, but measuring global oxygen balance alone, leads us down this alley of having hyperoxia associated with increased mortality. So there's a question mark over it. So global oxygen balance doesn't always equate to tissue oxygen balance. But then again, if we ask ourselves, how is lactate generated? Well, lactate, we know about the Krebs cycle, I guess, but I guess this is another cycle that we need to know about. It's a Cori cycle. And it looks quite simple. Well, but it won the discoverers Nobel Prize. So some simple things work. Well, on the right side, we have the generation of lactate through the process of glycolysis. So anything that speeds up glycolysis can increase lactate. And what can increase glycolysis without the need for tissue hypoxia? Well, we have sepsis alone. Sepsis without tissue hypoxia can increase lactate levels. We have beta agonists used. So it's very common for us when we apply salbutamol, nebulized salbutamol to people with severe asthma to have to see increased lactate. 6, 7, not unheard of, very common. Adrenaline use itself can increase lactate, and in some cases of lymphoma, also it can increase lactate to increase glycolysis. On the other side of the Cori cycle is uptake of lactate into cells, for example, liver cells, through a process of gluconeogenesis, and anything that blocks this process can also increase lactate. So what can happen? Liver failure, metformin toxicity. So you can see that there are many causes of hyperlactatemia without the need for tissue hypoxia. But then again, you can bring up evidence. So this evidence from Beth Israel Deaconess group to show that, well, lactate gives us additive information about prognosis on top of blood pressure alone. We know that if blood pressure drops, mortality goes up. And independently, as lactate goes up, mortality also goes up. And this also happens in patients with a normal blood pressure. So this is a phenomenon of occult hypoperfusion, if we believe that lactate is all due to tissue hypoxia alone. But then if you look at more recent evidence from Ospina, so this is a group from Colombia who has done work with Delny DeBarker, one of the preeminent intensivists throughout the world, we can see that, yes, okay, if we measure this thing called the CO2 gap, we can actually have an idea of what is the tissue oxygen balance. So they found that in group 4, which is the best group, with low lactate of less than 2 and a good tissue oxygen, survival is best. And on the other extreme, if lactate is high and tissue oxygen balance is bad, then mortality is worse. But there are two groups in the middle which actually constitute about 50% of the observational cohort with discordant results. High lactate and good oxygen, or lower lactate and bad oxygen. Funny. So these cohorts exist, and it really gives us doubt on whether tissue lactate itself tissue hypoxia is correlated with serum hyperlactatemia. Then, of course, one might want to bring up information, and this is information from the lactate trial, of whether we can actually target lactate as an endpoint of fluid resuscitation, i.e. to target lactate clearance. And if we run people with lactate down a very complicated protocol and try to bring down lactate, well, this group suggests that, targeting lactate seems to bring about better outcomes. So strictly speaking, when we see a divergence of the survival curve, that's good, but we have to look at a p-value, and strictly speaking, this p-value is more than 0.05. So not statistically significant, but they did a subgroup analysis for patients with sepsis alone, and really pure sepsis, and they found that, yes, it met statistical significance. But if you look at their results in detail, since they said they targeted lactate clearance, right, the lactate trajectory of both intervention group and the control group are virtually identical. So what could actually bring about the better management? And I think lactate to them and to most of us are just a way of alerting ourselves to being more careful with the treatment of patients. And as you have heard Matt say, there's now this new set of criteria, Q-SOFA score. These are purely clinical criteria, very easy to get, almost free to get. I think, we could actually use this criteria to alert us just the way that we use lactate for that. And certainly we should not use lactate as an endpoint of resuscitation. I don't think there's good evidence for that. And there are also many other things that we can look at for the patient. So I wonder who looks at the patient's knees, the legs. So if you look at the mottling pattern of the knees, you can actually see that, with people with more mottling will have a higher mortality. And strangely enough, people with more mottling also have a higher lactate. Well, so this is called a freebie me lactate for you. You can use that. And I can tell you when I use it, it responds very quickly to resuscitation. The mottling can just resolve as you increase the vasopressors, for example. It moves very, very quickly. So a very useful thing to look at. So I would say that lactate, if you can do it very quickly and easily, like in our ED, not a problem. But if you don't have it, I think don't worry, don't fret over it. It is not always necessary, I believe. And I think good clinical evaluation is probably even more important. So the other keystone of lactate management is that of, well, fluids. Well, we have been taught, at least I've been taught when I was a resident about 10 years ago, that we have to give lots of fluids. And the next day after a call, if I didn't give the patient 5 to 6 liters, I would have had it from a consultant. But I think the fear of underdosing fluids has come because we are always afraid of reducing flow to the patient's vital organs, thereby causing tissue hypoxia and purportedly death. But we might also realize that this curve of a relationship between fluid volume and complications from sepsis is a U-shaped curve. That means if we give too much fluids, we can actually generate tissue edema. And also, lately, there's some evidence, some basic science evidence on disruption of the endothelial glycocalyx. So it can also cause more mortality. And of course, this has been shown in multiple observational studies by even the SOAP investigators. But this is another one of the latest studies by J.L. Vinson in the critical care last year, showing that there's certainly a divergence of the survival curves between non-survivors and survivors based on the volume of fluid given. So both curves actually start off at 30 mL per kilo, which is the Surviving Sepsis campaign recommended dose of fluids on day 1. And you can see that for non-survivors, they actually build up a positive balance, 40 mL per kilo, while survivors actually probably manage to pass it out through the urine. So people who can pass it out survive more, despite our therapy. So, of course, that's observational studies. And I think one of the pivotal studies that actually highlights the fact that giving too much fluids is bad in sepsis, strangely actually came from the pediatric cohort. So I'm sure some of you actually attended a pediatric session earlier this morning. We showed that, in this trial is a FEAST study of 3,000 children in East Africa, many of whom had actually malaria, so a kind of different kind of sepsis. The patients, strangely, those that were randomized to the groups that received albumin bolus or saline bolus did equally bad. There was increased mortality over the group without the saline bolus. And the increase is not trivial, it's about 4% absolute increase. So 1 out of 25 children got harmed by the act of fluid bolusing. And this is easy to understand why. I think because sepsis is not primarily a hypovolemic state. It's just not. It is hypovolemia plus cardiogenic components plus vasodilatation or distributary shock. And in certain cases, there's also RV obstruction in the form of RV pressure and fluid overload. And of course, the treatments are markedly different. So we might think that, okay, LV dysfunction may be not so common, but actually it's been well known for many years, for the last 20 years, starting with Margaret Parker's seminal study in 1984, that the incidence of LV dysfunction is very high. Margaret Parker, she showed the incidence of 65%, and following studies, and studies that followed that actually showed a range between 18% to 60%, so fairly significant. And in our own cohort, we found that apart from LV systolic dysfunction, we also found quite a high incidence of this thing called acute cor pulmonale, 26%, and also other things like mitral regurgitation. But of all of these, the most important prognostic marker or echo abnormality is actually that of acute cor pulmonale. Our patients actually had an increased risk of death by 200%. So this is so important, and especially in the setting of acute respiratory distress syndrome plus sepsis, that one gets acute cor pulmonale, that we actually studied it, or rather the French studied it on a multi-centered basis. So this study by Miconto Desepes published last year, showing that among patients with ARDS, 21% developed acute cor pulmonale, and she developed a score. So patients that scored low basically said had a low risk of ACP or acute cor pulmonale, and they recommended echo on demand. And patients that scored high basically should require a routine echo to look out for ACP. And the treatment is completely different. I don't think we should give fluids in such a state. We should instead, lower ventilator pressures, limit the amount of hypercarbia that we give to limit the amount of pulmonary vasoconstriction, and also to consider early prone positioning. So that this is this entire package of strategies is called the RV protective strategies, not yet subject to the rigors of randomized controlled trial, but multiple observation studies have supported its use. So maybe you have to consider this. And I think it's heartwarming and also comforting that over the years, I think people have realized, at least under the randomized trial conditions, that we shouldn't use too much fluids. So Rivers in 2000 or 2001 actually used quite a lot of fluids, about 12 liters in the first 3 days of treatment. So that's a lot. And now around the time of the process, Arise and Promise Cells, the grade 3 trials published over the last 2 years, people have moderated that amount of fluids to about 6 to 8 liters. And that has been also accompanied by a decrease in mortality. Of course, there could be ecologic fallacies, but there's a general trend towards less fluids use and improved mortality. So I think for fluids, less is sometimes more, and accurate titration is probably more crucial to give fluids to those that would respond and to avoid fluids to those that wouldn't. So how do we actually titrate? Now, we have been, most of us in practice for quite a while, and we either think of ourselves as above average or average at least in terms of trying to deduce who is hypovolemic, who is euvolemic, who is hypervolemic, right? And indeed, that's the keystone of hyponatremia management. But let's see how well we do, right? So this is a very nice study from Sorgel in the Journal of Critical Care published 4 years ago, having 2 examiners compared against this thing called transpulmonary thermodilution. So how do these 2 examiners tell hypovolemia? Well, their sensitivity was ranging from 5 to 17%. That's bad, right, by any count. So specificity is a bit better, 80%. How about normal volemia? Well, the investigators or these examiners perform a bit better. And these examiners are actually intensivists. So they are not, very junior folk. 60% for sensitivity and specificity, 25 to 44%. So very low accuracy, and also quite big difference just between 2 examiners alone. And then, of course, for hypervolemia, sensitivity was anywhere from 8 to 26%, and specificity from 74 to 76%. So rather bad statistics. And if you use CVP, this cloud of dots, published by Shippey in 1984, again showed absolutely no relation between CVP and fluid status alone. And because of this, because physical examination and CVP are not so good, there's been proliferation of devices over the years trying to tell us whether patients should benefit from fluids or not. And this is really interesting because what has emerged from all these devices is actually echo. I see it a lot. I'm sure it's done a lot nowadays, because it's just so widely available now that people, instead of putting a probe to the heart, they also try to shift it down to the abdomen to look at the inferior vena cava. So who does inferior vena cava echo? Yeah, quite a lot, right? Yeah. So it's cool, it's funky, right? To see this tube of black, that varies with your respiration. And the thought is that there's respirophasic variation of the inferior vena cava. If you're underfilled, the thing tends to vary more. If you're filled well, it tends to be big and turgid. But is it really accurate? Well, there's a systematic review by Chang done just 2 years ago that showed that among the studies on inferior vena cava echo to predict fluid responsiveness, sensitivity was anywhere between 50 to 100. And specificity was similarly anywhere between 50 to 100. So there is quite great variation depending on which center or which study you look at. And this is a very good study just published last year by Michelle Slama's group in critical care. So it showed that if your amount of variation is less than 40%, which is the vast majority of results, you can't really tell between responders and non-responders. There's a great overlap of the dots, as you can see. And if the diameter, the absolute diameter of the inferior vena cava is less than about 2 cm, which again constitutes the vast majority of data points, there's again no way of telling between responders and non-responders. So I urge everybody to rethink again, whether the inferior vena cava ultrasound is going to really help you or just, waste your time. But ultrasound is definitely very useful. I personally love ultrasound. And I think instead of looking at the heart or inferior vena cava, perhaps you could just shift the probe to look at the lungs. So this is lung ultrasound 101. In about 10 seconds, you know about A lines and B lines. So A lines on the right side, okay, you see horizontal lines, dry lungs. B lines, vertical lines, wet lungs. It's so simple. So if there's a transition between A lines and B lines, it means that perhaps we are overloading the patient with fluids and giving rise to pulmonary edema. And indeed, this has been used in this set of rules called the Fluid Administration Limited by Lung Sonography, the FALS protocol. This is promulgated by the godfather of critical care ultrasound, Daniel Lichtenstein, published in Chest last year. So I urge you to just look at it to see whether you're convinced by his arguments. And indeed, ultrasound is really easy to use. Now, cardiac ultrasound, in our experience, we know that every person needs about 30 scans to achieve basic competency. That's quite a lot. But for lung ultrasound, even among non-physicians, we have shown that you just need about 10 scans to be good. 10 scans. That easy. So if you're pressed for time, do lung ultrasound. I think is a way to go. So lung ultrasound, I think, is good. And I think that for the IVC echo, not as good as it sounds. Not as good as it sounds. Okay. So we come now to this thing about blood pressure. No, blood pressure is so fundamental to sepsis management. Low blood pressure is part of the HEAD criteria, right? Or Quicksilver HEAD criteria. And I think the fundamental issue about blood pressure is that previously people have said that, even you measure blood pressure, it doesn't measure the good thing that comes about, which is stroke volume. Because stroke volume is, in essence, is the main thing that we want to optimize in sepsis. So this cloud of dots obviously don't show any relation. But I think if we measure the blood pressure and the stroke volume very closely, simultaneously, we do see some relation. And indeed, this is our ICU data, whereby we measured intra-arterial blood pressure and stroke volume using the flow track. It's not really the best instrument around, but it was available to us then. And we do see this cloud of dots, going in the same monotonic direction. And indeed, we use the changes of these pulse pressure to help us guide whether we should limit our fluid or not, especially when after fluid bolus, there's no change in pulse pressure. So I think blood pressure does have some relationship with stroke volume. And on top of that, the non-invasive blood pressure has value. Don't ignore that. Don't repeat it in all 4 limbs just because you don't trust the blood pressure in one limb, right? So regardless of the arm, the ankle, the thigh, okay, Karim Lakal's group has shown in a series of papers, about 3 papers over the course of 6 years, that NIBP, the non-invasive blood pressure, is good. It's accurate. Okay, it can tell hypotension, which is less than 65 mmHg, with quite great accuracy. It can tell you whether patients actually respond to fluid or not. Very, very useful to have. So, give it some credit. But the important thing about blood pressure measurements is that you have to measure it fast. After you give a fluid bolus, you have to measure it almost immediately, because even in fluid responders, the rise in blood pressure will only take place over the first hour, after which Neil Glassford and his team from Australia has shown that it would peter off, the effects will peter off. So, non-invasive blood pressure, if we measure it correctly and measure it fast after a fluid bolus, is actually quite accurate. So we should give it more credit. So in sum, what have we stated so far? I think we probably have to rethink. It's not to say that you must do this or you must do that, but to rethink some of this. That perhaps if the patient has a low blood pressure already, we should just treat him very seriously. And if you have no lactate, forget it. It's all right. Yeah, don't worry about it. Secondly, titrate fluids carefully. I don't think we need to stick to 30 ml per kilo very strictly. A lot of times in my practice, I actually use less than that, and patients turn out fine. Even in conditions like severe dengue, I'll limit fluids. Thirdly, no need for IVC echo. If you don't have it, never mind. Maybe you think of lung echo. It might be something more worth your while. And monitoring BP with a cuff is actually not a bad deal. So all these usual therapies seem to be very simple, may not be very good. But I think in the last couple of years, this sepsis trilogy of trials, each of them more than 1,000 patients or more, Process, Arise, and Promise trials. If you want to read about them, they are all in the New England Journal and JAMA, New England Journal, and summarized in Intensive Care Medicine. It shows that using complicated protocolized care doesn't actually give us a benefit over usual care. So I think if we do usual care well, we can actually do very much good for our patients. So coming back to our patient, our man with possible pneumonia that's quite severe, perhaps all we need is this: usual care that involves quick clinical diagnosis of sepsis. That's what we can do with the Quicksilver criteria. Titrate fluids well based on non-invasive blood pressure, and give early appropriate antibiotics and source control. Certainly nobody doubts the latter 2 points. And with this, I think we don't have to worry about giving best care, even if we don't have an ED that looks like this, and if your ED look like this, and even if we are out of ED in the field, okay, I think we can still give very good care to our patients, achieve optimal outcomes regardless of our resource limitations. And above all, I think good sepsis care should be done by all and be accessible by all patients. So thank you very much.